today we're going to be talking about OcuSim, which is the very exciting development of pathway communications, who've been using simulation in the context of eye care. And if you go on to the next slide, David, I can just introduce you a little bit more to the audience. We've been working with pathway communications for a little while now, and we've heard lots of exciting things about their work, so we were so pleased when they were agreed to come and speak to us and share with you some of the work that they've been doing. And the two people on the call today are Eren Demir, who's the Director of Pathway Communications, and David Southern, and they've been pioneering this work, and I'm going to hand over to them with the greatest of thanks to take you forward and to hear about some of their work. Thank you very much indeed.
Okay, welcome everybody. My name is David Southern. I'm one of the directors of Pathway Communications, and I'm going to take you through some of the softer side of OcuSim. And basically, we've built OcuSim as a simulation of intravitreal services. So, as a simulation of intravitreal services, and the intention of it is simply to create a detailed view of ophthalmology and intravitreal services to help organisations show the impact of change in their service. And the objective of all of that is to help get more patients treated. I don't know about the rest of the world, but in the UK, there is a serious problem within healthcare funding, and especially within ophthalmology. About 10% of the certainly outpatient activity is related to ophthalmology, and virtually all the ophthalmology departments we visit are very busy and in desperate need for this sort of help to help them reconfigure their services. It should be said that usually in the NHS what will happen is that service managers will reconfigure a service, implement it, and see what happens after they've made the change to see if that was successful or not. Clearly that's a high-risk strategy, and that's why we started looking at building simulation in ophthalmology in particular. So what OcuSim does, first part of what we do when we build OcuSim is to run a detailed forecast of patient-level data at the hospital. And this gives us some high-quality information that we then put into OcuSim, or the simulation. And then from that simulation, we produce a report. Eren will show you a bit later, there are many hundreds of variables within the simulation, and that allows us to really flex the simulation and show organisations what happens if they make changes. Is that a benefit or not? Is it the sort of thing they should be investing their time and effort in? So we take 36 data points, patient-level data, and forecast that forward. This is a really important aspect of OcuSim, as you know, rubbish in, rubbish out. So having patient-level data really does underpin the work we did in the simulation. So on top of that data, what we've done is on top of the patient-level data, what we've done is we've then created first off, just a schematic, which again Eren will show you a bit later, of the intravitreal pathway. I suppose it's worthwhile saying that the intravitreal services are services that look at the retina and helping patients with the back of the eye, diseases of the back of the eye. So we interviewed numbers of trusts to find out how the pathway worked before we converted that into a simulation. And it allows us to look at things that are really quite important or topical. So you can see at the top of this slide that we talk about things like treat and extend, which is a new methodology of treating patients, which actually means that they're going to inject patients more often, but get better response, and therefore in the long run spend less money. But if you're going to inject more patients more often in an already business service, you really have to know what the impact of that is going to be. The other thing that's quite important is always new devices or new products, drugs out. I know there are a few really exciting products coming forward that might have significant impact in the market. And what we want to do is be able to answer the questions for the service. Is it worthwhile taking on board this new product or new pharmaceutical product or new device within the service. So now, having quickly run through why we set it up, Eren's going to take you through some real results from OcuSim.
Hi everyone, my name is Eren Demir. I'm also a director at Pathway Communications and an academic at the University of Hertfordshire. What I'm going to do now is go through the details of the model, of the simulation model, and showcase some of the case studies that we've developed with a number of hospitals in England. So have a look at this particular category of patients, and we go back 2 years because it's 36 months related, and there's almost 1,000 patients who are not treated at all. So these patients are only come in for an assessment, for a review. There's no treatment going on. And so we would track these patients, and they are still in the service within the last 6 months. And the question is, if this 1,000, almost 1,000 patients are in the system and they're not treated, is there a possibility where we could have these patients within a virtual clinic, so this could be outside a hospital setting, and managed by nurses and optometrists instead of consultants and, well, the ophthalmology consultants. So if we shift this 1,000 from the hospital service, then what we have is we've got some excess capacity for new patients to come in. So that's the whole idea. What if we were to implement a virtual clinic where these patients are treated or where their condition is assessed, their eye condition is assessed outside the retinal service? What would happen? And that's what we're going to be testing here. Now, before we get into the details, I think if we have a look at this flow chart, that kind of gives us a better idea. Here we have 3 categories. We've got AMD, age-related macular degeneration, so that's just over 1,000 patients within this particular hospital. You've got diabetic retinopathy, which is the same as DMO, diabetic macular edema. Similarly, for medical retina, again, it's about 2,500 or thereabouts, patients are under observation. So they're not treated at all. Now the values below in brackets, the numbers, the small brackets, are the number of times these patients are either treated or checked or assessed in a year. So, for instance, AMD in year 1. So if a patient is in year 1, they're injected 4 times on average in year 1. In year 2, 3 times. In year 3, 2.5 times, and so on. And this kind of gives us a nice picture of the problem, because we can see that a lot of these patients are under observation and they're not treated. So what do? Let's have a look. So we developed this simulation for retinal services. The top part, where it says scheduling system, takes care of the appointment booking system of that particular service. So we would try to mimic their appointment booking system within the model. So there's a lot of coding behind that. The middle layer is where patients come into the service, the new patients come in for diagnosis, they go through some diagnosis process, and you could either be treated, which is the bottom layer, okay, or you can have a follow-up. So you kind of loop around. You're hardly ever discharged once you're within a retinal service and you're under their treatment. Patients never are discharged. So they're always in care. So what happens is these patients loop around. And what I could do is I could quickly go through some of the inputs we have in the model. It's quite a large number of inputs, actually. It's in the region of hundreds. So what I'd like to do is if I can just wait a few seconds until you can see the screen. I know it takes time just to kind of get started. This part over here where it says input data monthly forecast is all the forecasted activity. So that's where David said we would carry out some develop some statistical models and find out the number of patients they come in for the first time, the number of patients where they are followed up, how many cancelled appointments, how many patients are rebooked, and so on. We then have in the middle part the appointment booking system. So a patient could be assigned to an age-related macular degeneration clinic on a Monday morning, or a diabetic macular edema on a Thursday afternoon. So we would assign patients according to these to this particular clinic review sheet. We then have a lot of inputs, if I can scroll all the way down here, about the distributions, i.e. the rate parameters. So how many times are these patients injected in year 1? How many times are they injected in year 2? And so on. The model enables us to compare the two scenarios. So we might want to compare the current system, which is scenario 1, versus a scenario 2. We may want to increase the number of injections, which is the treat and extend example that David gave. And we might want to have a new medication. So Lucentis is typically what's used out there for injecting the patient, but it could be some other drug. What happens if we were to use Eylea? So on. So these are all the information we would input in terms of capturing the treatment process. There's also some information about the input data related to the revenue. Each process, each treatment or a follow-up assessment has some sort of a revenue. Well, these drugs have some sort of a costing. The costing for resources in terms of your staffing and so on. And also your clinician rota system. This is quite important because clinicians are not available all the time Monday to Friday. So we would have, clinician 1 is only available Monday morning and Monday afternoon, and also Wednesday morning and Thursday morning, and so on. So all of these inputs are fed into the model, and we would run the model, and it generates our results. There are a huge number of results. I'm not going to go through all of them, but typically you've got some information about your arrivals, your 95% confidence intervals, you've got your follow-ups, for instance, the number of times these patients come back, the utilization of your doctors, what's the percentage they're utilized, the utilization of your nurses, the injection beds, the theatres, and so on. Just carries on. There's a huge number of outputs. Okay, so I'm not going to go into the details, but that should kind of give you a bit of a flavour. And we would generate a report for the particular hospital. So it'll be some sort of a fairly easy to understand report in a graphical format. So there we are. It's a report going through some of the where the outputs are explained, just in a nutshell. Okay, and so this would be a report provided to the hospital in a PDF format. What I now want to do is now go through some of the case studies that we've developed. So for a number of hospitals. So here we are. I'm just going to wait a few seconds until you can all see the slide. So what we have is, we're now testing the model with a virtual clinic. As I mentioned earlier on, we've got 970 patients. We've seen them in the last 6 months. Nothing has been done for this category of patients, no form of treatment. We're going to shift these patients out of the service into a virtual clinic, possibly managed by a nurse or an optometrist, where they would take the pictures of the eye using some sort of a machine, and that would be remotely sent to a consultant for them to assess. So as a result of this, the current service on average has about 735 follow-ups. When we shift these patients out of the service, this comes down to about 660 on average per month, on average. Now, given that to a certain extent, we now have capacity for new patients to come in. So what if we increase the number of new arrivals by 25%? So that now increases our follow-ups to about 777. So the percentage increase is about 6%. But let's not forget, 25% increase in new referrals is quite large for a hospital that's struggling to keep up with the increasing demand. And you can have a look at the utilization of your consultants. So the current service is at 74% as a result of virtual clinic and increase in referrals. That goes up to about 78%. And the interesting thing for the hospital is the values right at the bottom row. So you're increasing you're increasing your surplus by 21%. So you're not only allowing new patients to come through, they're out there waiting for weeks for treatment, but you're also increasing your revenue and your surplus, which means this could potentially be for the hospital, possibly for new consultants, nurses, new pieces of kit, and so on. Here's another a case study. Again, this is for the same hospital. We've got a virtual clinic plus treat and extend. Now, what the treat and extend is a new treatment regime. On average, most hospitals inject their patients on average about 4 or 5 times in a year for a patient, whereas the guideline says this should be somewhere in the region of 7 or 8. More injection means you need more capacity in terms of the doctors and nurses. Well, virtual clinic pressure, and we can now implement treat and extend. So this means we would provide more treatment. More treatment means better outcome. It's clear in the literature. There's evidence that if we were to, and which reduces the risk of loss of vision for patients, better quality of life, and so on. So if we go ahead and implement treat and extend, again, you can have a look at the utilization of a consultant, for instance, from current service 73% to about 71%. So the utilization does not change for an ophthalmologist here. So there is a better outcome at the end of the tunnel here for the patient. And whereas in this case, your utilization hardly changes. Look at the percentage change column, -5, -2. So it's very, very small change. And yet again, you're increasing your surplus by about 8%. So just in summary, what this particular shows is the virtual clinic, again, relieves the pressure for us to be able to treat our patients with more injections, okay, and it has the capability or the opportunity for a better outcome here. And the final scenario, I'm just going to wait another few more seconds for the slide to come through, if it hasn't yet. Now, the final example that we're going to be showing here is for another hospital. Now, the problem with this hospital is they've got a huge number of diabetic macular edema patients. So these are diabetes related. And the orange trend line clearly shows the increase in the number of May 13, hardly any patients coming through. Whereas have a look at August 2016 or September 2016, our forecasts, they are in the region of hundreds. So, and that trend is expected to increase. Now, this hospital is running at 100% capacity. There's absolutely no room for new patients. So what do they do? There's no money to open up new clinics. There's hardly any cash for new consultants. And so one approach or another approach would be to have nurse injectors. So if you have a look at the current service where it says consultant utilization, it's 98%, almost 100%. Consultants are very busy. There's some evidence over here that specialist nurses could be trained to inject patients in the eye, so for them to carry out the treatment instead of a consultant. Now, nurse injectors are cheaper option than a consultant or a specialist doctor. Now, what happens if we have 2 nurses trained to inject the patients? Now, we would run the model with 2 nurse injectors, and you can clearly see that this reduces a consultant's utilization to 78%. So that then opens or the opportunity or leaves us there is some capacity for new patients to come through. Now, in our previous slide, that DMO is an increase in trend. Let's assume, based on that increase in trend, there is a 5% increase in DMO arrivals on that particular category. So each month, that increases by about 5%. Now, in this case, because they're new patients, they would have to be diagnosed and assessed by a consultant. And when they're treated, they come back again, and they would be treated, they would be assessed, further assessments. That then increases the consultant utilization to about 97%. So 2 nurse injectors enables us to kind of free the capacity for new DML patients to come in. What if we were to implement a new medication? So typically, most patients are injected with 2 drugs, and they're called Lucentis and Eylea. And these patients tend to be treated around 7 or 8 times in a year. Whereas if we were to use a new drug called Ozurdex, that would reduce the number of injections to about 2. That reduces the number of assessments as well. So what happens if we have these nurse injectors along with consultants? Our DMO arrivals increases by 5%, and we increase the use of Ozurdex by about 35%. So we still have quite a fair number of patients treated with Lucentis and Eylea. And if we have a look, the consultant utilization in the 4th column over here reduces down to about 90%. And we have an excess revenue of about 3%. Again, that clearly shows that we can test the system with a combination of changes and kind of see the impact that it has on the hospital. Okay, and that kind of completes at least the demonstration of OcuSim. We've published a fair number of papers now and OcuSim is currently well, it will soon be published in a journal. Okay, and that kind of completes the webinar. Thank you.
Thank you so much for talking to us. That's absolutely fascinating. Just a couple of questions, if you don't mind, that have come through whilst you've been speaking. Could you give us a bit of a sense of how long it takes you to set up a model like this?
Okay. Well, the first thing is we would need the patient level data, hospital data. Okay. That's for us to be able to carry out the forecasting. That's for us to be able to examine the existing number of times the patient is treated in their 1st year of treatment, 2nd year of treatment, 3rd year, and including the follow-ups. We would also need some information about the clinic reviews, so which day of the week our patients, and some of them could be AMD.
Can you hear me?
And so on. So typically, we're looking about 2 to 4 weeks. So from getting hold of this data set, it's 2 to 4 weeks. We would have the model set up for that particular hospital.
It looks like you've done this in a number of different hospitals. And have you found the same model is relevant in a whole range of different places, have you?
Yeah, so we spent quite a bit of time developing the concept of this model, and we interviewed a wide range of experts from different hospitals to make sure that the simulation, once we built it, was suitable for all hospitals. So we've set it up so it can accept anything that's thrown at us.
Well, that's pretty impressive. I think it's not many people do that with simulations, unless there are people on the call who can tell us otherwise, which would be great. Another question we had was, can you use this model with? Do you think you could use this or a similar model with another outpatient specialty?
Well, it depends. Is it within ophthalmology, or it depends on the type of specialty we're dealing with? I mean,
so in terms of the core aspects of the simulation, yes, we can. So booking systems, those sorts of things, yes, they are repeatable. But as you know, the patient flow will change, and that's going to. So if, for example, we've been asked to look at urology, and we're going to have to look at urology from scratch, even though we know parts of what we've already developed will work, but the actual flow of patients changes, and we need to start from the beginning for a new specialty.
Yes. Yes. No, I'd like to echo the questioner's sort of interest in this, because if you've cracked, if you like, a simulation that can answer any question about a specialty, if you think of the time that it takes for people to build an individual simulation, if your simulation can do that without somebody having to learn how to build a model, that's incredibly time-saving and very valuable for a large range of people.
That's the key, really. So our customers in ophthalmology don't have to understand simulation, and what we do then is actually effectively speed up their whole decision-making process from, as you know, what can be many months, possibly even years in the development, into a matter of a few months. We can show them a range of scenarios quickly and accurately, far more accurately than they can, and then they can make decisions to change much more quickly than they would have done otherwise.
Yes, that's good. And have you got examples of where people have made that decision and moved on to adopt a new way of working?
Yeah, we've worked with a couple of hospitals so far who are doing that. So this is obviously quite new, but we're on to our 4th hospital at the moment.
Fantastic. Well, thank you so much for taking the time to talk to us today. Absolutely fascinating what you've done, and I think it opens up a whole new way of using simulation more broadly across healthcare. What we'll do is make this webinar and the slides available on our website, so people can see them and listen to it again, or again share it with colleagues. And we also have a simulation LinkedIn page called Simulating Health. Actually, David, if you could go one slide further on, I think it probably gives the details on that. We will post up the question and answers on that site, and people can link to it. And David and Eren, are you happy to have further conversations with people if they want to contact you on LinkedIn about this?
Yeah, we're delighted. Yep, absolutely.
Great. Okay, well, thank you so much for your input today. Thank you very much to everybody who joined. We'll have another webinar which we'll let you know about next month. But I hope you all agree with me that this has been incredibly interesting, and I hope you found it as valuable as I have. Thank you.
Thank you. Bye-bye. Bye.